So I'll be talking about my work in the context of primary health services and how they respond to diabetes, and also about the role and context of diabetes educators in diabetes management and prevention in general, but also at North Richmond Community Health. And I'll also talk about how we're trying to integrate our work in the diabetes education service with the oral health program here and with the local community mental health service. So just to continue on from Christine, estimates of the number of Australians with diabetes range from 1 to 1.7 million, and of these 85% have type 2 and 12% have type 1. Furthermore, a landmark study, AusDiab, in 2000 estimated that 16%, or approximately 2.5 million of Australian adults over the age of 25 years had pre-diabetes. That is, they have glucose levels between the normal range and diabetes, so they're on the way to getting diabetes. So that might be impaired fasting glucose or impaired glucose tolerance. A follow-up study, AusDiab 2012, found that among the same cohort of people, so the same people were followed up 12 years later, the incidence of new diabetes was 0.7% per annum. Now, we know that the prevalence of diabetes is much higher and outcomes are more likely to be severe in high-risk people. And in particular, these are people of lower socioeconomic status, people of cultural and linguistic diversity, people of Aboriginal backgrounds, and also those with severe and chronic mental illness. And as we've said, these people are also likely to have poor oral health. The Australian National Diabetes Strategy 2016 to 2020 was released 3 years ago in 2013, and its goals included prevention of type 2 diabetes, promotion of awareness and early detection of diabetes, reduction of impact of complications and improvement of quality of life for people with diabetes, and particularly among the high-risk groups. It's founded on guiding principles of collaboration and cooperation across government and organisations, and coordination and integration of diabetes care across services and sectors. And we're working towards these goals and principles at North Richmond. The strategy's goals depend heavily on primary care services, especially GPs, who are central to screening, prevention, diagnosis and management of diabetes. There's evidence that intervention with people at high risk of diabetes to change their behaviours can be effective in preventing diabetes or at least delaying its onset. GPs can target those of their patients who have risk factors and target them for screening, and then refer on for education and support for risk reduction or management of diabetes when it develops. The Oz Risk tool was developed to provide rapid assessment of risk for diabetes. It uses an 11-point questionnaire, and it can be self-administered or administered by a health professional, or can be given out at appointments or left in waiting rooms, and it's also available online. We have a pad of AusRisk tool single sheets at the registration desk, so if you'd like to grab one afterwards, you're welcome. In Victoria, the AusD Risk tool can be used to assess eligibility for the LIFE program. And this is a diabetes prevention program which is evidence-based, and it's targeting people at high risk of diabetes and focuses on making sustained changes in diet, exercise and weight. This is done through structured courses and through telephone coaching programs. It's run through Diabetes Victoria at many locations, including here at North Richmond, and it's funded by the Victorian Government and free to most people. Now, in addressing diabetes, GPs are supported by Royal Australian College of General Practice guidelines and by Medicare chronic disease management items, which fund planned care that includes regular monitoring and review, treatment, referral and education. GPs also receive a Medicare payment for completing the diabetes cycle of care for their patients, which includes regular monitoring for major complications of diabetes. Ideally, a GP practice will systematically target and recall patients with or at risk of diabetes for monitoring and treatment, using a planned team approach. Diabetes educators, dietitians and other allied health professionals are routinely involved in this, and medical specialists can be included if needed. Integrated multidisciplinary care is widely seen as essential to good diabetes management. However, attention to the relevance of oral health in diabetes care is lacking and it's slow to improve. The RACGP guidelines and National Health and Medical Research Council guidelines for diabetes don't include poor oral health as a risk factor or as a prompt for screening for diabetes. Basic oral health risk assessment or monitoring is not usual as part of diabetes management in primary care, and it's absent from the list of checks required to complete the diabetes cycle of care as well. Referrals, understandably, without the help of these prompts, referrals between oral health services and diabetes services in either direction are uncommon. Now, credentialed diabetes educators have a role in both prevention and management of diabetes. Credentialed diabetes educators have completed a postgraduate specialist qualification in addition to their basic health discipline, and then have gone on to do a credentialing process. Once credentialed, they can obtain a Medicare provider number and they can bill under some Medicare items. Credentialed diabetes educators come from a range of disciplines. Some are dietitians, pharmacists or podiatrists, and I know of at least one who is a dentist. However, most credentialed diabetes educators are registered nurses, coming from varied backgrounds in general nursing. We're able to work independently, and we also work closely alongside GPs, specialists and other health professionals, and we do so in private and public clinics, in hospitals and in community health centres. Our practice is founded on philosophical principles of empowerment and holistic person-centred care, and we seek to educate and support people with diabetes or at risk of diabetes to develop understanding, behaviours and skills for self-management to meet their own goals. We also provide clinical management to our patients, and we support others in the care team in doing this. Potentially, we're able to help build bridges between agencies and disciplines in healthcare, perhaps because we're particularly integrated, we work particularly closely with a wide range of other health professionals and other practices. And we spend a lot more time with our patients than most other health service providers working with people with diabetes. Here at North Richmond Community Health, I'm one of 2 credentialed diabetes educator registered nurses, and we work closely with the range of other services within this organisation, and we're also closely linked with medical, allied health and mental health services in the local community and local hospitals. We provide individual and group services, including the LIFE program and Type 2 diabetes group education programs. And our funding is mixed, coming from state government community health program, from the LIFE program itself and from Medicare. North Richmond serves a diverse community, as you've heard, and we have many people in categories of high risk of diabetes and other illness. And for these people, engagement with health services and effective intervention in the disease process is often problematic for a wide number of reasons. So we've been developing new models of care and trying to link with other disciplines and services to improve our engagement with hard-to-access groups. And we're trying to provide more integrated, holistic care with clients. And in the process of this, we're also hoping to raise awareness of the broader relevance and impact on health of diabetes for the clients and also for the workers in these other areas. The first collaborative project is with the local Clarendon Community Mental Health Clinic. So the diabetes educators attend Clarendon once a week to provide healthy cooking groups and appointments at clinic or home visits for the clients attending Clarendon, usually with alongside their clients' case managers. So we try to support healthy behaviour change and also maintain or instigate monitoring and treatment for diabetes if needed. We're also trying to help address general physical health as well, and we try to facilitate engagement and referral to medical and oral health and other services here at North Richmond Community Health and elsewhere. And we're trying to provide staff education and promote awareness of physical health and diabetes risks among the staff at Clarendon. At North Richmond Community Health, the oral health and diabetes education services have long recognised we've got a mutual interest in reaching clients at risk who attend the other service. So we've developed systems for basic assessment and referral between our services. Diabetes education clients are asked about their last oral health assessment and signs and symptoms of oral health problems and offered referral for further assessment or treatment if needed. Oral health clients are offered the AUSD risk assessment, and then if they score if that shows they're at high risk, they're offered referral to the diabetes educators, or if they have already got pre-existing diabetes. Education on the links between diabetes and oral health is provided to clients in both our programs. Lulu will discuss her work on this project in more detail following me. Okay. Both projects have had mixed success and continue to evolve, and we continue to learn from this. What we've learned is that collaborating with other agencies and service areas can be effective, but it requires work and it requires time. Success is more likely if you strive to understand and work with the culture of the other organisations and the professions, and not just focus on the patients or the clients. It's also important that you're ready to adapt and that you can get management support to embed change, because that's what's really needed in the way we approach the work and the way the other agency does their work as well. And it's also important to ensure that your collaboration is seen to support the achievements of goals for everyone, not just for your particular area of interest or service. So in finishing, on a broad level, I think some systemic changes can support closer cooperation and integration between oral health care and diabetes care. For example, the Royal Australian College of General Practitioner guidelines could highlight poor oral health as a flag for screening for diabetes and promote oral health care as part of diabetes management. We could also include a regular oral health check as part of the diabetes cycle of care when we're monitoring complications. And perhaps it is time to talk again, as I think you mentioned earlier, talk about the introduction of a Medicare rebate for at least some oral health care. Perhaps at least for people with diabetes, which may be an examination or education. And it may be done through an allied health referral as part of the GP, the general practice care plan. And I think we need to do more, as others have said. We do need to do more to promote the evidence which already exists and gather more evidence on the relationship between oral health and diabetes and metabolic syndrome, and also on the benefits of treatment on outcomes in both areas. Okay, thank you.